what percentage of veterans use the mail order pharmacy, and are they pleased with it by and large?
I could only tell you from limited feedback that I've received from veterans. The majority of the veterans that I work with or have been in contact with use the mail order pharmacy since we're in rural northern Maine, and the feedback has been positive. Very good. Thank you. Mr. McIntyre, to assist the VA in working down their identified backlog for care, it is my understanding that Tri-West will hire an additional 100 employees and an additional 100 the following week. What kind of system do you have in place to monitor the effectiveness of their training and ensure these employees are properly scheduling appointments and processing claims?
We already had 100 people in process doing that work. We took our training programs, looked at them through the other set of the lenses backwards to figure out what refinements we could make to shorten the training. Those folks are in the process of doing the easiest part of appointing as they get spooled up to be able to do this, and we will be measuring their performance just like we measure every other staff person's performance in that critical work.
Well, what is your policy as far as disciplining or reprimanding an employee if they're not doing their job, improper scheduling, or processing claims? Do you have a policy in place?
You bet. We monitor very carefully where gaps are in performance. We put people on corrective action plans. If the issues that they work are viewed as a problem that can't be corrected with counseling, then we will release them on the spot. We found a very dedicated workforce that, together with all of us, wants to be able to serve veterans, just as is true for the providers in our networks.
Thank you. Question for Mr. McIntyre and then Mr. Corrado as well. In both your testimonies, you mentioned that with any new program, no matter how well the design or preparation, areas of enhancement will be detected in early stages. So areas of enhancement, I'll say again, will be detected in the early stages. Can you share with this committee some of those challenges?
What we've discovered is the fact that there needs to change some of the authorization processes that were being discussed previously. Those have been put on the table. The notion of making sure that we refine how we actually do physical appointing with the veterans to make sure that we're dropping the no-show rate even further. The way in which people come to understand the program itself and how it executes, because that's change, both for the veteran but also for the VA Medical Center staff themselves.
Mr. Corrado?
Yeah, a couple of things. One is I do think we need to continually educate the VAMC staff on the benefits of the program. Mr. McIntyre alluded to some issues that our network providers bring to us, and that's not unusual, that the authorization requirement is one. The other issue that we've discovered and we're talking to the VA about is the requirement that all care go to network providers. In some situations, as an example, you don't know what anesthesiologist is going to scrub for surgery on a given day, and that anesthesiologist may not be a network provider. So I think some allowance for a percentage of non-network providers to support our veterans. This really is the only program that I support that has a requirement for 100% network providers. There's always an allowance for some non-net providers, and I think that would actually increase our ability to serve our veterans.
Very good. One last question for you, sir. What kind of information does VA share, and or what information do you have access to regarding the veterans process within the PC3 program?
Regarding the veterans process within the PC?
Yeah, correct.
The internal VA process? There's sharing of that information, and we're having ongoing conversations, because I think the intent on all parties is to improve processes, and particularly those that are impacting access to timely care.
I'd echo the same.
What are the performance measures you track besides and beyond profit?
We have a responsibility to appoint people within a certain time frame. We track that. We track the volume of work that our staff is taking to complete. We track the providers that we're required to have from our perspective based on the demand that we see by facility and the location of veterans. And we track claims payment on the back end. And we track the return of medical documentation back from the provider to the VA to make sure that the medical record, when that person ends up back in the VA needing care, is going to be complete. We track about 40 other metrics, but those are the ones that top of mind would probably be most important to making sure that we're staying focused on the very performance of what's going on here. What I'll tell you is, this year, our company is paying $20 million for the privilege of doing this work. And the reason for that is, and I'm not complaining, because we do that voluntarily. The reason is you pay to build your own infrastructure, and then you get paid for the work as it arrives. And that requires advanced investment. And so we do that willingly, and we believe at the end of the day that this program is going to be a good match to the direct delivery system, just as TRICARE is to the Defense Department.
Thank you.
Yeah, and we're an ISO 9000 certified organization, so we really focus on tracking performance metrics. Dave mentioned some of the more significant ones, but we have a program management review that we conduct monthly where we track all of the metrics that the VA uses to monitor our performance. And I can tell you that so far things are going well. We also have a very detailed quality assurance surveillance program that we use, and I think that so far, we have been performing well against those metrics.
Mr. Makovsky, information VA released last week revealed that over 57,000 veterans have been waiting 90 days or more for their first VA medical appointment, and 64,000 veterans who have enrolled in the VA healthcare system over the last decade never received the appointment they requested. That is 121,000 veterans who have not been provided the care they have earned and deserve. Why did the Department allow these veterans to wait months and even years in some cases on a VA waiting list instead of referring them to a non-VA provider to receive the care that they needed?
Congressman, I will tell you that for the 57,000 on the electronic work list, we are working that process now with accelerating care. For the new enrollee appointment request, which you referenced, which was roughly 64,000, you are correct. That is just not excusable. We should have had our eye on that. We did not. I will tell you one thing that our staff did as they assessed all veterans who had not received an appointment yet. Out of an abundance of caution, here's what we did. If a veteran had an enrollment processed at a VA medical center and we could not definitively identify an appointment in that facility, don't care if they were seen anywhere else in our system, but if they applied in the Tampa VA, for instance, and they did not have an appointment there, we went all the way back to the beginning of an enrollment and added them to our contact list. So as of the 64,000 where we were before, as of this morning, and I think we will be producing an additional update, we were below 30,000 to contact. We are working that list aggressively. We should not have let it slip, but we did, out of an abundance of caution, pull everybody we could imagine.
Yeah, I just can't.
Yes.
I just don't understand. It's reprehensible, inexcusable that these veterans would have to wait that long, in some months and years. Anyway, what interaction exists between the non-VA care and the VA's electronic waiting list?
Right now, what we've done with accelerating care, we produced directive out to the field. What we asked the field to do, and we published their productivity numbers, their capacity numbers, and their efficiency numbers. The first order of business was to determine whether or not they could increase their capacity. If they could not run an extra clinic, an extra half-day clinic, evening hours or weekend hours. They were directed to identify capacity in the community. One of the things we did with that, our PC3 program office shared all of our data with the PC3 prime contractors so that they would have that available. Their instruction was if they could not find it inside the facility, to then refer that to care in the community through non-VA care. We made over $300 million available in supplemental As of yesterday evening close of business, $127 million of that supplemental had already been obligated for non-VA care episodes.
Next question, sir, for you. I understand from your testimony that claims processing activities for non-VA care are either centralized at the VISN level or decentralized at the facility level. How much variance did you find from location to location on how non-VA claims are processed throughout VA, and what effect do you think such variance has to the timeliness and accuracy of non-VA care claims processing?
If that's for me, sir?
Yes.
Look,
For you.
I'd be candid. I think that the variability does exist site to site. We began in October. One item that we focused on, in addition to claims payment accuracy, which we focused on throughout all of FY13, beginning in FY14, our drive was really to make sure, quite simply, that we paid our bills on time, irrespective of the distributed nature. So we've been focusing on each one of our claims payment centers, whether it's a VISN or facility level. But a distributed system does have variability.
Mr. Williamson, can you comment on that, please?
Well, we looked at a number of systems, some of which were centralized at the VISN level and others that were at individual VAMCs. And we didn't really see a variation in the quality of the claims processing. It was pretty much a pattern of a lot of errors, no matter what the system was.
Thank you.